equal to 1000 ml.
Direct start.
Hello. 1000 ml or blood loss accompanied by sign or symptom of hypovolemia. We all know great monuments, that is Taj Mahal, which is built after the death of Mumtaz, and Mumtaz died in PPH. So no Shahjahan should build Taj Mahal in the memory of Mumtaz. So it is better to control PPH. PPH causes 4 out of 10 maternal death in developing countries like India. And more than 125,000 women die of obstetric hemorrhage every year. And these are the recent guidelines available from these references. If you see impact of maternal mortality in India, 1/4 of all maternal death worldwide, PPH accounts 35 to 56% of maternal death in India. The 5 most common direct cause of pregnancy-related mortality in India is postpartum hemorrhage. If you see generalized causes like unsafe abortion, sepsis, hypertensive disorder, but the PPH is the most common killer, and these all are the references coming from the 17th September 2021. So all are the recent guidelines we had taken for you to aware that PPH is a very big burden on the society. If we define the type of PPH, there is 2, primary and secondary. What do we mean by primary PPH? Is a major cause of morbidity and mortality that occurs in first 24 hours following the delivery. Usually it is just after the removal of placenta or when the placenta is in situ. Secondary means an excessive bleeding from the genital tract occurs between 24 hours and 12 weeks postnatally after delivery. That is secondary PPH. But the most common and detrimental is primary PPH. In India, 2 to 4% of vaginal delivery has got PPH and 6% of delivery after cesarean section. And this is the National Health Report. A small blood loss that makes the woman hemodynamically unstable is also termed at PPH. Suppose she has got 6 grams of hemoglobin and she has lost 500 ml to 1000 ml of blood, means 6 grams becomes 4 grams. She will be severely anemic. She was already anemic, severely anemic. There will be very big hypovolemic shock and she can die. And this has happened recently in our town. So we have to aware, we have to take very good care. Prevention is better than cure. So make all women physiology and risk factor in PPH. Always 40, tone, tissue, trauma, and thrombosis. Tone means overdistension of uterus, multiple pregnancy, uterine muscle fatigue with over oxytocin use or uterine contracting agent we are using for induction of labor. If she has got already infection or she is covered with premature rupture of membrane, chorioamnionitis, uterus distortion or anomaly like bicornuate uterus, septate uterus, unicornuate uterus, uterine relaxing drugs if we had used, that is isosuxaprine to control the labor pain, or ritodrine or terbutaline, whichever drug we had used to control the preterm labor, and then it is not controlled, and when gone for delivery, that is uterine relaxing agent can cause PPH. Retained placenta and membrane, incomplete delivery at the time of placenta or placental cord tanglement and some cotyledons are left, that is tissue. Cervical and vaginal tear, extended tear in cesarean section, sometimes the tear can goes up to the right uterine artery, both uterine artery. Uterine rupture, particularly in the cases of previous cesarean section, and uterine inversion. Thrombine means coagulopathy. So in coagulopathy, if patient is suffering from any blood dyschariasis or disorder of blood coagulation, we have to take care. And most common is uterine atony, that is tone. More than 50% of the cases in which uterus become flabby and toneless uterus. And here this drug comes as a marvelous rescue to increase the tone in uterine atony. If we see the abnormality of uterine contraction or uterine atony occurs usually in arcuate uterus. Risk factors are prolonged use of atonic uterus, that prolonged use of oxytocin, high parity, chorioamnionitis, or patient undergone general anesthesia, overdistended in cases of multiple pregnancy, polyhydramnios or fetal macrosomia. Nowadays, more diabetic patients become pregnant and macrosomias are there. Multiple fibroid with pregnancy and she is carrying baby, all the chances that she can go for PPH. Uterine inversion because of excessive contraction short umbilical cord or fundal placement of the placenta, and suddenly somebody has pulled this cord and there is a inversion of uterus and that cause PPH. Genital tract trauma, either episiotomy, very big. Episiotomy can reach up to cervix. So sometimes there is big episiotomy, can reach up to the cervix. Vagina, lots of perineal laceration. If she is a previous cesarean section, can go for scar rupture. Or somebody has tried forceps and forceps has gone inside the uterine cavity into the abdomen. There is a rupture of uterus. Precipitates delivery. Retained placental tissue like retained placenta and placenta accreta. So for that, we have to go for CT or MRI for confirmation. Now, good ultrasound can detect that there is a placenta accreta, percreta, or increta. This is known as placenta accreta syndrome, PAS. We can diagnose by ultrasound. So prevention is better than cure. If there is a placenta accreta or percreta, we can advise them to go for hysterectomy while during cesarean section. Never pull the placenta, or there is a previous uterine surgery. Nowadays, we are getting more and more pregnancy with post-myomectomy pregnancy, and this is a very big scar. The placenta is adherent over there. There are all the chances that placenta can perforate into the uterine myometrium. So it is a accreta. If goes beyond, that is a percreta. So we have to take care of all this retained placental tissue and placenta accreta syndrome. If she is suffering from abnormal coagulation, like if patient has got preeclampsia or severe infection or amniotic fluid embolism or therapeutic anticoagulation. Nowadays, we have got all the patients who had replaced the valve. So they are all on warfarin. So we have to convert them from warfarin into our less coagulating agent, like we are giving them the heparin, that is low molecular weight heparin. We have to stop before at least 15 days, but in emergency, if she comes, we have to take care of all this anticoagulation. If patient has got abnormal bleeding or there is a IUD and placental abruption, so patient can go for DIC, current thromboembolism treatment patient is on. So all are the risk factors we have to take care in our brain, that if patient is going for this type of things, we have to prevent. And this all are the guidelines of coming from the obstetrics and gynecology, October 2017. So how you diagnose? Blood loss can be estimated by weight or compresses or visual estimation, collecting device or calculation of the shock index. The severity of this condition can be estimated by more than 500 ml, accompanied by risk, that is abnormal condition. More than 1,000, there is a severe PPH. If it goes for more than 2,000, there is a massive hemorrhage. But visually, the blood is coming pouring just like a tap water from the cervix, and uterus is totally flabby. Most of the time, it is atony of the uterus. Again, go for motive, massage the uterus, oxytocin, see for any tissue inside the uterine cavity, and give oxytocic agents. And recently, we will discuss that carbetocine is very good agent in making this atonic uterus contractile. So what are the guidelines available in the management of PPH? First, prevention and management of postpartum hemorrhage. What is this level +1 and level +1 evidence? The significant reduction in the need of further uterotonics compared with oxytocin for those undergoing a cesarean but not for vaginal. No statistical significant difference between carbetocin and oxytocin in use of risk of PPH, because both are the daughter of same mother. If we see the guideline from this is Society of Obstetrics and Gynecology of Canada, they recommended that carbetocin 100 microgram given as IV bolus over 1 minute should be used for prevention of PPH in elective cesarean delivery. So if you are considering that this patient can go for PPH, you can electively use carbetocin after the delivery of placenta as suggested by Society of Obstetrics and Gynecology of Canada. And this is level 1+2 evidence. If we see the WHO recommendation for the prevention of PPH, WHO recommends that this is a publication in 2012. You can download this evidence from 2018 UpNet, and this is book available online. It is free of cost. Anybody wants to download, they can download. The book says the use of effective uterotonic for the prevention of PPH during third stage of labor is recommended in all birth, because we don't know that which lady can go for PPH. So prevention is better than cure. To effectively prevent PPH, only one of the following uterotonics should be used. The use of carbetocin 100 microgram IM or IV is recommended for prevention of PPH in all birth in context with cost is comparable to other effective uterotonics. Either you go for vaginal or cesarean for prevention of PPH. These are the so many things: carbetocin, misoprostol, methyl ergometrin, oxytocin we can use. But last slide I will show you that if you use all these things and if you use only carbetocin, it is a cost effective and we can control the PPH very well with single drug rather than responded on so many different uterotonic agents. If we see the guideline of American College of Obstetrics and Gynecology 2017, it also says to prevention of postpartum hemorrhage, you can use carbetocin. So how we can use different uterotonic agent for the active management of postpartum hemorrhage? Oxytocin is there in our armamentarium. We can use IV oxytocin 10 to 40 units in 500 to 1000 ml of continuous IV infusion. We can give intramuscular 10 units. Methyl ergometrin time tested 0.2 milligram every 2 to 4 hourly. 15 methyl PGF2 alpha 0.25, or we can give 0.25 intramyometrial into the uterine myometrium in the personals in between these 2 points. We can use every 15 to 90 minutes, and maximum dose we can give, that is 8 doses. We can repeat prostaglandin for 8 doses. We can use misoprostol 600 to 1000 microgram, either oral, sublingual or rectal, but this is one-time drug. We cannot repeat this drug. Except this, you can repeat this all three, but misoprostol is a single dose. What is international consensus statement for the use of uterotonic agent during cesarean section? If we think carbetocin is a longer acting analog of oxytocin with similar mechanism of action and adverse profile, so we had used oxytocin since years together, and there is a very good molecule of oxytocin general, that is carbetocin. Increased duration of action of carbetocin compared with oxytocin eliminates the requirement of infusion after the initial dose. So if you want to control PPH, we have to put this in IV fluids and it should go continuously. Therefore, it become a preferred drug, first line treatment rather than oxytocin. And this is a beautiful paper on the international consensus, and they did multi-central trial. And in summary, they found that oxytocin, carbetocin is the only molecule you can use judiciously as a one single uterotonic agent during cesarean section. If we see FIGO 2020, FIGO and ICM. What we mean by ICM? International Federation of Obstetrics and Gynecology, or International Confederation of Midwives, strongly recommend the use of uterotonic during active management of third stage of labor to prevent PPH either during vaginal or cesarean section. WHO says the recommendations are allied with those made of WHO 2018 recommends an uterotonic to prevent postpartum hemorrhage. Because if you don't want to lose mother in PPH, use judiciously oxytocin or in your armamentarium. Rather than taking 4 swords, if you have got big missile with you in form of carbetocin, you can use single drug that will cover all these different molecules and give very good uterine tone in uterine atony, because uterine atony is the most common thing by which there is a PPH. I will not recommend carbetocin in a trauma. If there is a cervical tear, you have to repair the cervical tear. If there is extension of uterine scar, we have to suture that. Here, your carbetocin or any uterotonic agents doesn't work. What are the FIGO recommendation or drug regimen for the prevention of treatment of PPH? PPH prevention is prophylactic portion. Oxytocin, first line, 10 international unit either IM or 5 international units slow IV push for the first minute after the delivery. So after the delivery, we should be ready with this, and after insertion of this, we can remove the placenta. Ergometrin 0.2 milligram IV within the first minute after delivery. Book says you should give methyl ergometrin at the delivery of anterior shoulder in vaginal or after delivery of baby in cesarean section. Misoprostol, if oxytocin is not available or cannot be safely used, 600 milligram orally within the first minute of delivery, or you can put it rectally also, and both are equally effective. And we had done study of misoprostol rectal insertion before cesarean section, and believe me, it turns out to be very good, and it will decrease the blood loss and it will decrease the PPH. If PPH threatens, what are the treatment options? This is a prophylaxis. But if there is a PPH, you found that uterus is flabby, you can use 10 unit international, 5 unit international unit slow IV push, or you can repeat up to 40 international unit in IV infusion. We can put one ampoule is containing 5 unit. So 40 means you can use 40 divided by 5. 8 ampoules you can put in a single IV infusion. If you consider the cost of 8 ampoule and consider the single dose of carbetocine, we will discuss this. You can use misoprostol 800 milligrams sublingually if you have a 200 microgram tablets. You can use methyl ergometrin 0.2 milligram and can be repeated every 2 to 4 hours with maximum of 5 doses over a period of 24 hours. Symptometrin, that is a combination of oxytocin and ergometrin. You can give 1 ampoule. Nowadays it is not available. Previously it was freely available. You can use carbetocin 100 microgram IV, IM or IV over 1 minute, or you can use carboprost and maximum you can use 2 gram. That is a 8 doses because 1 dose contains 0.25. And previously we have got 1.25. That is a bigger dose. But now everybody is available with 0.25. So we can use 8 doses. What is our own FOXY recommendation for the control of PPH? FOXY recommends active management to prevent PPH in all cesarean sections. Oxytocin IM or IV diluted is the recommended uterotonic drug for the prevention of PPH in cesarean section. How we can use oxytocin? Same, 10 unit intramuscular, 5 unit IV, or 20 unit in 500 ml of normal saline. Action will be in 2 to 3 minutes and last up to 15 to 20 minutes. If you use misoprostol 600 microgram orally, sublingually, or perrectally, onset of action is 3 to 5 minutes. Peak will be there in 20 to 30 minutes and effect lasts for 75 minutes. Methyl ergometrin 0.2 milligram IM, onset of action is 2 to 7 minutes and effect lasts for 2 to 4 minutes. If you use carboprost 250 microgram, onset is 1 to 2 minutes, lasts for 15 to 20 minutes. So all are very short lasting uterotonics except methyl ergometrin, which goes for more than 75 minutes, and methyl ergometrin 2 to 4 hours. In 62nd All India Congress in Obstetrics and Gynecology held in 2019 and again we have got 2020 Indore conference live after the COVID section. In that conference we have discussed carbetocin in atonic PPH. Total duration of single injectable intravenous carbetocin in uterine atony is about 1 hour. Hence, only single dose is sufficient. Carbetocin has got potent uterotonic effect on pregnant and immediate postpartum uterus and no effect on grown gravid uterus. So don't try to use this carbetocin in non-gravid uterus. Bioavailability is very good, 75 to 80%. What is carbetocin? Just a long-awaited oxytocin? Although oxytocin is most widely used agent, there are several limitations which makes room for introduction of newer agent. What are the limitations of oxytocin? Short half-life, 3 to 17 minutes. A continuous IV infusion is necessary to achieve sustained uterotonic activity. For elective cesarean section, slow 0.3 to 1 unit of bolus of oxytocin over 1 minute, followed by infusion of 5 to 10 internationals, 1 to 2 ampoule for 4 hours is required to prevent PPH. Larger doses of oxytocin is associated with adverse effect, like sometimes it's got hypotension, nausea and vomiting, dysarrhythmias, STT changes, sometimes can cause pulmonary edema and severe water intoxication with inconvulsion. So these limitations are targeted by introduction of new molecule, and that is carbetocin. Carbetocin is available as 100 microgram per ml in a vial. What is the mechanism of action? Again, it is a synthetic oxytocin analogs that binds to same myometrium receptor as oxytocin with similar affinity. Long-acting synthetic non-peptide analog of oxytocin with agonist property. Very good statement. Long-lasting or long-acting synthetic non-peptide analog oxytocin with agonist property. Carbetocin selectively binds to oxytocin receptor present on the smooth musculature on the uterus, resulting in rhythmic contraction of the uterus, increasing frequency of existing contraction and increasing uterine tone. Plasma half-life is 40 minutes, so 4 to 10 times longer than oxytocin. Onset of contraction starts within 2 minutes, and duration of action after single intravenous dose is 1 hour. So, act by binding to myometrial oxygen receptor. It gives rhythmic uterine contraction. It will increase the uterine tone. So, Society of Obstetrics and Gynecology of Canada recommends carbetocin as the first choice of uterotonic agent to prevent PPH as elective caesarean delivery. All are elective because in emergency you may expect some complication, but in elective surgery, nobody accept or want any complication. So prevention is better than cure. So they are using this drug as a first line treatment, and these all are references coming in September 2021. So what is the pharmacokinetics? How these drugs get absorbed? Peak concentration within 20 to 30 minutes. So bioavailability is 80%. How it distributes? Distribution of half-life is 5 to 5 minutes. Metabolism usually eliminates primary by non-renal routes. So you can use this drug in renal complication patients also. Eliminated half-life by carbetocin was 41 minutes. So it's excreted within 40 minutes from the body via non-renal routes or via the renal routes. Pharmacokinetics, 40 minutes plasma half-life, 4 to 10 times longer than the oxytocin. Onset of action, 2 minutes within 90% of the patient. Act long enough to prevent postpartum hemorrhage in immediately postpartum periods, because the duration of action after single intravenous injection of carbetocin is 1 hour when given IM or IV and 2 hours when given IM injection. Prolonged action compared to oxytocin because it has got longer half-life. So increased uterine tone and reduction in the risk of PPH in elective surgery section, where 1 dose of carbetocin is equal to 16-hour oxytocin infusion, and we don't have any postpartum complication that we described in previous slides. What are the indication and doses? We can use this drug for prevention of postpartum hemorrhage due to uterine atony. Posology is cesarean section under epidural or spinal anesthesia. Withdraw 1 ml of carbetocin 100 microgram and administered by intravenous injection under adequate supervision in hospital. Always use after removal of placenta. Okay, this is the beauty of this drug. Then it will make the uterus stony hard. You can use IV administration. Carbetocin must be administered after the delivery of infant and as soon as possible after the delivery of placenta. For intravenous administration, carbetocin must be administered very slowly over 1 minute. So always take that 1 ml injection, dilute in 9 ml of normal saline, take 10 ml syringe and give it slowly IV. This is the method we follow, because 1 ml you can't give up to 1 minute. So better to dilute it and go give it very slowly. Carbetocin is used for single use, so no further doses is required. Contraindication, you cannot use during pregnancy or labor. If baby is inside, must not be used for induction of labor. This is like oxytocin. We can use oxytocin for induction of labor, but we cannot use carbetocin for induction of labor. If there is hypersensitivity of carbetocin or oxytocin, beware, don't use it. If patient has got hepatic or renal disease, don't use it. Serious cardiovascular disorders, patient is on anticoagulant and patient is suffering from cardiovascular stroke, or patient has got epilepsy and patient is on anti-epileptic drug, don't use this drug. So these are the few contraindications. In special population, when use in pregnancy prior to the delivery of infant is not contraindicated. Breastfeeding, small amount of carbetocin have been shown that plasma leak is there in breastfeeding. So woman with gut deformity, or when it is assumed that it is degraded by gut, breastfeeding does not need to be restricted after the use of carbetocin, because we'll know after 40 minutes drugs is excreted, and first feed even after cesarean section will be after 3 to 4 hours, because mother is under anesthesia. So there is least risk of getting into the baby's circulation. Now, safety and efficacy of carbetocin has not been established in pediatric group because we don't have any study, and we had not used on non-gravid uterus. So in geriatric, it is not recommended. What are the drugs which can get interact with this carbetocin? No drug interaction have been identified with analgesics, spasmolytics agent, or epidural or spinal anesthesia. So there is no drug indication if you are using general anesthesia or spinal anesthesia, or if you are giving any analgesics post-operatively, either use pessary or injectable, you can use it. Due to similarity with oxytocin, occurrence in interference known to be associated with oxytocin cannot be excluded. So severe hypotension has been reported with oxytocin within 3 to 4 hours following the prophylactic administration of vasomotor or conjugation with caudal block anesthesia. May enhance the blood pressure enhancing agent like alkaloids such as methylergometrin. Like oxytocin, carbetocin effect may be potentiated with prostaglandin. Some inhalation anesthetics such like halothane or cyclopropane may enhance the hypotensive effect and weakens the effect of carbetocin on the uterus. Arrhythmia have been reported for the oxytocin during concomitant use. So it is better not to use with oxytocin, either use oxytocin or use carbetocin. So what is the summary of adverse reaction? What are the system and organ class? Blood and lymphatic system disorder is very common. A patient has got anemia. Nervous system disorder, patient may have got headache and tremor, or it is a blood loss is there is a dizziness and anxiety. Visual disorders like hypotension and flushing, tachycardia, respiratory tract infection like chest infection, GI disorder like nausea, abdominal pain, vomiting, or sometimes metallic taste, and some patient may suffering from pruritus. So what are the clinical studies available for carbetocin in our armamentarium? First study is coming from the oxytocin and uses the meta-analysis of randomized control trial in cesarean delivery from the Taiwan, and it is in 2018 study. It is a Taiwan Journal of Obstetrics and Gynecology. Said carbetocin versus oxytocin for the prevention of postpartum hemorrhage. This is a meta-analysis of randomized control trial. And material methods they use, there is electronic database where search for randomized control trial comparing carbetocin with oxytocin involving cesarean delivery. Non-randomized trial, non-cesarean delivery studies which did not directly compare carbetocin to oxytocin, and studies which not analyze the intended outcome were excluded. Outcome were analyzed for postpartum hemorrhage, additional use of uterotonic and transfusion requirement. And what they found, summary of this study, they compare this study with Canada Center, Italy Center, United Kingdom Center, Malaysia, Egypt, and Australia. These are the carbetocin people use, and this is oxytocin they use, and this is the total number of patients. If you see, the biggest study is of Canada Multicenter, is electively and excluded previa and absorption. All these studies are elective and emergency. Emergency excluded multiple pregnancy, and more than half has got cesarean delivery in active stage of labor. So what are the intervention they found? They found that if you use carbetocin, out of 1,001 patient, only 141 patient has required, that is 14.34 patient has got PPH. Compared to oxytocin, there is 70%. These are the patient in which they have to use additional uterotonic. So if you see the transfusion ratio, blood transfusion required in oxytocin group is 4.97 compared to carbetocin use is 1.49. So very few patient has to undergo blood transfusion. Here the transfusion rate is very high. And if you see the comparison of postpartum hemorrhage with the use of all this trial in carbetocin, the effect of prevention is very good, that is only 14%. These are the some another reference of the, or you can see the odd ratio. If you see the odd ratio of total, which favors, this is carbetocin, this is oxytocin, you can see it favors usage of carbetocin because the risk ratio of PPH with carbetocin is 0.79. It favors carbetocin. Again, if you use additional uterotonic agent with carbetocin and oxytocin, relative or risk ratio with carbetocin is only 0.57. Yes, only 0.57. Strongly favors carbetocin. If you see the transfusion carbetocin versus oxytocin, relative risk ratio is only 0.31. This is 1, this is plus, this is minus. So you can see the overall ratio of carbetocin strongly favors either in use of additional uterotonic agent, prevention of PPH, or in transfusion medicine. This study says that it favors carbetocin. So conclusion, carbetocine is effective in reducing the use of additional uterotonics, reduction in postpartum hemorrhage, and reduces the requirement of transfusion. And this is very good study conducted in Taiwan Obstetrics and Gynecological Journal 2018. What is our Cochrane database? Because whenever see any study, we used to believe that Cochrane database is the final answer. Cochrane database review all the study in carbetocine preventing the PPPH. Objective of that study is to determine if the use of oxytocin, that is carbetocine, against agonist is effective in conventional uterotonic agent to prevent PPH. Search method, all data, because this is our library. So all data was collected from Cochrane Pregnancy and Childbirth Group trial from March 2011, Cochrane Central Registry, that is Central Trial of 2011, Medline and Embrace in 2011. They found that there is 11 randomized control trial, including more than 2,635. Selection criteria was used was randomized control trial comparing carbetocine with other uterotonic agent or with placebo or no treatment in prevention of PH. All data was collected. Two review authors independently assessed the trial for inclusion and assessment of bias and extracted data. What primary outcome came? Severe postpartum hemorrhage, that is PPH, measured clinically estimated blood level of 1,000 or more are defined by all trial authors, irrespective of mode of delivery. Maternal death or severe morbidity, either major surgery or multi-organ failure, or patient has good admission in ICU, hyperpyrexia, are defined by the trial authors. What they found? Carbetocine for prevention of PPH, comparison, one carbetocine versus postpartum outcome, only one postpartum hemorrhage. You see, this is the odd ratio, favors carbetocine, favors oxytocin. And they found it is equivocal. The risk of PPH was lower in the group of receiving carbetocine compared to group receiving oxytocin. These all are the patients, those who receive carbetocine. You see, risk is either good or nil compared to oxytocin. So it doesn't favor oxytocin, it favors carbetocine. And they found all these in our very good mother matter, that is Cochrane database. And this Cochrane database at the end says that use of carbetocine compared with use of oxytocin was associated with reduced need of subsequent therapeutic uterotonic. So this is a single drug regime that favors carbetocine. So one carbetocine versus oxytocin outcome, only additional uterotonic therapy doesn't require. So it will give good uterine contraction compared to this. This is the same result. If you see favors carbetocine, this favors carbetocine, carbetocine for prevention of PPH. There is no difference in the need of blood transfusion between carbetocine and oxytocin group because relative risk is 0.080. So if we compare between carbetocine and oxytocin, showed that women who had carbetocine less likely to have heavy bleeding and less likely to require other medicament which produce uterine contraction following the cesarean section. And this study, believe me, comes in 2012. So since this drug is available in market as a uterotonic agent. This is very good Journal of Maternal and Fetal Neonatal Medicine. It says that efficacy of carbetocine in prevention of PPH, they conducted a systematic review, and this is Bayesian meta-analysis of randomized trial with objective to estimate the efficacy of carbetocine and prevention of PPH. They had taken 30 randomized studies comparing carbetocine to other uterotonic agent, and they used all engines like Medline, Scopus, Embrace, and Cochrane library. What they found result compared to oxytocin? Carbetocine was associated with reduced need of additional uterotonic, woman undergoing cesarean section with relative risk of 0.43, lesser risk in postpartum transfusion, very few patients has to undergo blood transfusion. Carbetocine is effective in reducing the need of additional uterotonic use and postpartum transfusion in women with increased risk of PPH undergoing cesarean section. Again, Indian International Journal of Obstetrics and Obstetric Anesthesia, they had also conducted a systematic and meta review with objective of reduce the requirement of additional uterotonic during cesarean section undergoing non-elective cesarean section. They found 5 randomized trial with more than 1,240 patients undergoing non-elective cesarean delivery, where carbetocin was compared with oxytocin. Primary outcome, patients were needed for additional uterotonic. What is the result? Additional uterotonic was reduced when used on compared with oxytocin with odd ratio of 0.03. So this is odd ratio. You can see this favors carbetocin and this all favors oxytocin. So what they concluded, carbetocin reduces the need of additional uterotonic in non-elective all emergency cesarean section compared with oxytocin. This is Menton-Hazel odd ratio, MH odd ratio for need of additional uterotonic, and they had conducted all these trials of 2015 to 2016. What is the efficacy of carbetocin in preventing postpartum hemorrhage after cesarean section in twin pregnancy? And this is a multiple pregnancy, uterus is distended. Objective was to prevent prospective study to compare the effectiveness of carbetocin and oxytocin in PPH during twin delivery. 166 twin pregnancy at term undergoing elective or emergency cesarean section. They used on one arm 100 microgram of oxytocin compared with oxytocin protocol, that is 20 international unit. And you can see in carbetocin percentage additional uterotonic agent was very less, only 3.4. And if you see the fall of HB is very less. So this is a very strong uterotonic agent. So carbetocin is most effective than oxytocin in prevention of PPH in population with twin pregnancy delivery by cesarean section. So if we compare between the carbetocin and oxytocin in active management of labor of third stage in preventing postpartum hemorrhage, and you can refer my book of active management of labor, which is very well accepted by Royal College as a active management of labor and active management of third stage of labor. At that time, carbetocin was not available in market, so we had not discussed it, but we had discussed that something new will come in market for the prevention of PPH in armamentarium. So objective was to compare the effectiveness of carbetocin and oxytocin in management of third stage of labor. What the method? 300 women undergoing normal vaginal delivery was collectively enrolled. They are divided into two groups. One group was treated with carbetocin 100 microgram IV, and another group was treated with 10 unit of oxytocin. And postpartum was developed only in 23 women with carbetocin and 31 patients with oxytocin group respectively. So significantly higher number of patients was treated with balloon catheter in oxytocin group than carbetocin group. 13 patients in oxytocin group and 4 patients in carbetocin group needed ICU. So in comparison, carbetocin turns out to be better oxytocin in the management of third stage of labor compared to prevention of postpartum hemorrhage in normal delivery. So active management of third stage of labor and prevention of postpartum hemorrhage, the objective was to review the clinical aspect of PPH to provide guidelines in assisting clinician to prevent PPH management. These guidelines are updated from previous Society of Obstetrics and Gynecology, that is Society of Canada, and Clinical Practice in PPH, published in 2000. So this guideline was published before 21 years. So carbetocin 100 microgram given as IV, bolus over 1 minute, should be used instead of continuous oxytocin infusion in elective cesarean section for the prevention of PPH to decrease the need of other therapeutic uterotonics. For women delivering vaginally with one risk factor of PPH, you can see there is a PIH, there is a multiple pregnancy, there is a malpresentation, uterine anomaly. So additional factor in which we can think of PPH, carbetocin IM decrease the need of uterine massage to prevent PPH when compared with continuous oxytocin infusion. And this study has come in 2009. So uncontrolled before after study adding carbetocin in addition to oxytocin decrease the blood loss for cesarean section in twin pregnancy. This is a second question. So if we had used any uterotonic agent and still uterus is not contracted, so we can use carbetocin as a second molecule. So to evaluate the effectiveness of adding carbetocin to the regular uterotonic agent for the prevention of PPH after cesarean section of twin delivery, there is a retrospective uncontrolled before and after study in women with twin pregnancy. In control group, they had used oxytocin infusion and direct uterine injection. In study group, they had used 100 microgram of carbetocin. What is primary endpoint? Change in hemoglobin. If there is PPH, hemoglobin will be less. The risk of PPH and undiagnosed PPH, HB drop more than 2 gram per deciliter, blood loss, and need for additional uterotonic agent and blood transfusion. These are the secondary endpoint. And what they found, after adding the confounding factor, the change in HB from 0.35 to 0.3 and the incidence of PPH with odd ratio of 0.30 were comparable in both the groups. However, with the moment what undiagnosed PPH is decreased and total blood flow in 24 delivery is also decreased. So they concluded that use of carbetocine in addition to regular uterotonic agent decrease the blood loss in undiagnosed PPH. So we had used oxytocin, but we found that uterus is not contracted. You can use carbetocine as a second line drug if you are not using first line drug to prevent the PPH. And this study was published in 2021. So in summary, these are the different studies available worldwide. One in HY, carbetocine versus oxytocin. Carbetocine is effective in reducing the use of additional uterotonic reduction in postpartum hemorrhage and transfusion when used during cesarean section. SU-LL, that is a Cochrane review, carbetocine versus oxytocin. If you compare carbetocine with oxytocin, showed that women who had carbetocine was less likely to have heavy bleeding and less likely to require other medicament to produce uterine contraction following cesarean section. Study by Calafat E, carbetocine in prevention of PPH. Carbetocine is effective in reducing the need of additional uterotonic use and postpartum blood transfusion in women with increased risk of PPH during cesarean. On VDN, carbetocine versus oxytocin in non-elective cesarean section. So all are emergency patients. Carbetocine reduces the need of additional uterotonic in non-elective cesarean section compared to oxytocin. Sotelo L, efficacy of carbetocine for prevention of postpartum bleeding after cesarean section delivery in twin pregnancy. Carbetocine is most effective than oxytocin in prevention of PPH in population with twin pregnancy delivered by cesarean section. Akhtar P has comparison with carbetocine and oxytocin in active management of labor in third stage of labor in prevention of PPH. Carbetocine is better than oxytocin in management of third stage. Ludec D, active management in third stage of labor in prevention of PPH. Carbetocine 100 microgram given as IV bolus over 1 minute should be used instead of continuous oxytocin infusion in elective cesarean section for prevention of PPH. That is a therapeutic 1B evidence. HSU-WW, controlled, uncontrolled before and study after adding carbetocine in oxytocin cesarean section in twin pregnancy. You can use carbetocine as an additional agent to decrease the blood loss in undiagnosed PPH. And this is the summary of all the study we had taken from this different journal. And one last thing, if you use 5 oxytocin, cost is 99 rupees. 2 methergine, cost is 16 rupees. 1 prostaglandin, 203 rupees. 1 misoprostol, 88 rupees. So considering this, it comes around 408 rupees. If you use single molecule of carbetocine available in market by 2 companies, one is 444 and this drug is available at 510. So we can use this drug single molecule, and rather wasting time using 4 different drugs, we can give 1 ml diluted with 9 ml, 10 ml slowly over 1 minute. When you start your uterine contraction, uterus will be stony hard. So in summary, carbetocine is loss-limiting synthetic oxytocin analogs and also works by stimulating the uterus. All guidelines recommend that carbetocine 100 microgram given as IV bolus over 1 minute for the prevention of PPH in elective cesarean section. It has got longer half-life compared to oxytocin, that is 40 minutes. You can use as a single bolus dose, achieve sustained uterotonic activity. It is effective in reducing the use of additional uterotonics, reducing in postpartum hemorrhage, transfusion when used during cesarean section. So ultimately, our aim is to make all our women happy.
Actually.
And all should be happy. There is no PPH.
The time to be happy is now, and the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right here. The time to be happy is now, and the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right here.
Thank you. Thank you very much. Any questions are welcome. Thank you. I'm just stop sharing my this presentation, and I hope everybody might like this presentation. So any question, I will see you on chat box. I don't think anybody had posted anything on chat box. It is empty. So I will write that thank you.
Thank you, sir. This was a very nice and informative session as usual, and the very
you.
difficult topic with the very easiest method, sir. So
Thank you.
once
Thank you.
again, I really thank you for this, sir. Sir, we sure that it will help those who are attendees and those who are upcoming doctor, and also it will use in day-to-day practice. So, sir, lots of thanks, sir.
Thank you, Nishant, and thank you, Bharat Serum, for coming out with this very good molecule. It is available worldwide since years together because it is recommended by WHO, it is recommended by Cochrane, and it is a very good uterotonic agent. And in India, when we used to study in our obstetrics, it used to say that every 1 minute, one woman is dying of PPH. So if we say 1 or 2 women with using this drug, it is a service to mankind and service to humanity to save women from PPH. And this is the only thing we can really do wonder with our in our practice to save women. So thank you very much.
Thank you, sir. Thank you, sir. इस पेशेंट की सेफ्टी जर्नी में सर हमको आपका ब्लेसिंग चाहिए. So we need your blessing.
Thank you. Thank you. Thank you.
Sir, we hope and we wish that you and your family will be very safe in this time, sir. Ever and ever, sir.
Third wave of Omicron, that is Amir Khan. Now in Mumbai they put 144 and we
144, yes.
So it should not come in Gujarat. So again, do SMS, wear mask, safe distance, and wash your hand. So
wash your hands,
thank you very much.
Very right.
Thanks a lot. So I'm just leaving the meeting. I hope it is almost 1 hour. So thank you very much.
Sir.
And thanks again for giving me opportunity to have my views on this wonderful molecule. So thank you very much.
Thank you, sir. Thank you.